Hello. Thank you for joining us today. We have some really exciting news. I'm David O'Malley from The Ohio State University, where I lead the Division of Gynecological Oncology and our Phase 1 GYN oncology program. One of the great honors I have is also helping lead the ovarian cancer portfolio for GOG Partners. Over time, one of my favorite things is the friends I've made through GOG, the network, GOG Foundation, GOG Partners. Emmy Zeros is one of those friends, become one of my best friends in the field. I am honored to have the chair of the Department of GYN Oncology from Roswell Park Comprehensive Cancer Center in Buffalo, New York, where she holds the Shashti Lely Endowed Chair, one of my friends and mentors, and what a great chair to have. Emmy, well, thank you for joining. You started at Northwestern, worked under Kukos at Penn. Now you're the chair of Roswell Park GYN Oncology. How are you doing? How are you excited? What's going on?
Thank you, Dave, for the introduction, and thank you for having me today for this exciting discussion. Yes, I started working in immunotherapy when I was a fellow, and it was always my passion to advance the field in immunotherapy for ovarian cancer patients. So this week has been particularly exciting with the first IO approval in the
Oh,
platinum-resistant recurrent ovarian cancer
no,
patients.
no. You didn't say IO approval in ovarian cancer, did you?
Yes, yes, I
No,
did.
no, no. We have 10,000 negative patient trials here. You're telling me B96 approved on February 10th to be utilized with weekly paclitaxel plus or minus Bev in first or second line therapy in IO in ovarian cancer. So I want you to get to that about an IO. We'll get there. But tell me, you were instrumental in the design of B96 based on your lab data and your clinical data. So tell me, why did we get this approval on February 10th of 2026? Tell me about B96, Emmy.
Yes, thank you, Dave. Really exciting data. And we were very emotional yesterday seeing that the approval, because this is indeed a very historical milestone in our field. So before we get into the details of Keynote B96, I just want to take a few minutes to walk everyone through the data. So we have a chance to review it together. I'm only going to spend a few minutes and then we will get into some exciting questions and answers about what it means for our daily practice. So Keynote B96 was a large randomized phase 3 double-blinded clinical trial enrolling over 640 patients internationally, all of them who had platinum-resistant recurrent ovarian cancer and who had received one or two prior lines of treatment. More importantly, prior bevacizumab, PARP inhibition, and checkpoint blockade was allowed for enrollment on the clinical trial. So patients on this clinical trial, as you can see on the figure, were randomized into two arms, receiving pembrolizumab or placebo, plus weekly paclitaxel, which was continuous, so there was no break. It was a Q3-week regimen, in combination with bevacizumab per investigator choice. The primary endpoint of the clinical trial was progression-free survival by investigator assessment, and the key secondary endpoint was overall survival. So in this table, you can take a look at the patient characteristics that enrolled on this clinical trial, but in summary, they were real-world high-risk patients. Most of them received two prior lines of chemotherapies. About half of them had bevacizumab exposure, and the majority of the patients who enrolled on this clinical trial had a really short platinum-free interval, so 3 months or less than 3 months. So this population where outcomes are historically been extremely poor and where treatment decisions are often challenging in daily practice.
So Emmy, yeah, a lot of people are driving, so I can't see the table here. So let's reiterate that. So 73% of patients had Bev, and it was supplied in the trial. So it didn't matter. There wasn't, if you wanted to give Bev, you gave Bev. So about 27% did not, probably other factors like risk of bowel perforation or renal dysfunction.
That's
Only
correct.
1 to 2 So only 1 to 2 priors, and one third, 35, 37%, 36% had one. So the highest risk population of that primary platinum resistant.
Mhm.
Okay, so one third first line, two-thirds
Mhm.
second line, 74-ish% had Bev, and also that shorter platinum-free interval. I'm not sure what to make of that in the second line therapy, but I think those other two facts are important. Okay, thank you for setting the stage. It's a really important because it's a different patient population than some of our PROC trials.
Yes. And I think you pointed out a really good point that the bevacizumab was supplied on the clinical study. So even in countries where it was not available, the investigator could choose to give bevacizumab to the patient. So this could be different from some of the clinical trials where maybe it may not be available for all the investigators.
And 46% had Bev before, so it's Bev
Yes,
after. So much higher than some of the other, older trials we had. So also a very important point. I'm sorry for interrupting you. That's just
that's
such an important
correct.
point. All right. Thank you.
Yes. So moving on to the efficacy data, here you can see the progression-free survival, and this is with longer follow-up and the second interim analysis. And you can see a consistent, durable progression-free survival benefit with the addition of pembrolizumab. So here you can see that the benefit is observed both in patients with PDL CPS greater or equal than 1, and in the overall intent to treat patient population. And importantly, it is maintained over time rather than representing an early or transient separation. You can see from the curve that the median progression-free survival was 8.3 versus 7.2 months in the PD-L1 expressing cohort versus 8.3 and 6.4 months in the intention to treat cohort. And hazard ratio is around 0.75.
So I think this is a really interesting point. If we watch, somebody says, "Oh, these are banana curves." I think I said that, right? But
Yes, you have.
yeah, right. But the PROC patient population, they're always going to be banana curves. We're not curing anybody in PROC. So it's really interesting. They don't really come together until about 27-ish months there. And you're about to show us the overall survival, which I
Yes.
think is
Mhm.
really one of the most interesting. So really interesting, clear separation of the curves. The medians completely underestimate the benefit here. It's the hazard ratio 0.75, 25% improvement. So I'm on the edge of my seat. Every time I see this, I get excited. OS, is that the next one? I think that's the next one, right?
Yes. Overall survival. Let's move on to that. So most exciting data for the KEYNOTE-B96 is that it's demonstrated a statistically significant and clinically meaningful overall survival benefit in patients with PD-L1 expressing tumor. Here you can see the hazard ratio of 0.76, and you can see the differences in overall survival, which is 18.2 months versus 14.0 month in the control arm. So this represents the first phase 3 study to show an overall survival benefit with an immune checkpoint inhibitor-based regimen in ovarian cancer. So as you can see that the separation here is durable and the survival observed here is among one of the longest reported in this platinum-resistant setting, particularly given the strength of the control arm.
So separation very quickly, even starting to see at 3 months for survival. Maintained and beyond 6 to 9 months separates further and is maintained, kind of comes together. Very small numbers are at 27 months.
Correct.
And then the tails, a telltale, no pun intended, of a little pun intended, of IO therapy is separation of the tails. Now we're talking very small numbers here, but
Correct.
but clear separation of the curves that persist. And I'm really interested. Now, this was the final OS at the interim, but I really hope that we see long term in OS in this. And again, ultimately, those are going to come together, but it's really interesting how we see separation persist with this IO therapy.
Yes, that's correct. So you can see the separation was maintained over time. And we do know that sometimes that tail end of the curve in recurrent ovarian cancer is quite noisy. There are a few patients, so there's a lot of censoring going on. And post-progression therapy can be really diverse in this cohort of patients. So sometimes it's really hard to interpret the tail of that curve because this is a really tough disease biologically, and patients, in general, just do really poorly after platinum-resistant disease started with so many prior lines of exposures.
So what do we see about toxicity on this? Did we see differentiation?
Yes. So from the safety perspective, there was no new safety signal. Toxicities were consistent with what we expect from the weekly paclitaxel and pembrolizumab, and immune-mediated adverse events were generally really manageable. So this is really importantly aligns with how we use taxanes in a clinical settings, starting the regimen and adjusting as needed based on tolerability. And this is what happened in the clinical trial as well. So for example, if your patient was unable to tolerate any of these regimens, you were allowed to discontinue that and continue with the one or two additional study drug that your patient was receiving. So why is this important? Because we understand that weekly paclitaxel is a really intense regimen, and sometimes being on that for a very long time can be very challenging for our patients. However, KEYNOTE-B96 did allow to drop the Taxol if your patient had stable disease or had toxicity, or you felt like it was the patient's best interest, and you had a chance to continue with the IO plus bevacizumab combination or placebo plus bevacizumab combination, depending on how your patient got randomized.
So we were sitting at a lunch table in, I think in Berlin at ESMO, if I remember
Mm-hmm.
correctly, and you really caught my attention. So tell me, on clinical trial, a lot of these decisions are somewhat made for us. When can we discontinue? Decreasing for toxicity. Now, this regimen's interesting because we're not getting that 3 out of 4 weeks. Is continual without that break, like you emphasized. So
Yes.
tell me, real world, this regimen, you probably use as much as anybody in the world.
Mm-hmm.
Tell me, real world, how are you doing this day? How are you using this regimen day in and day out? Just from an overall, you kind of hinted at this, dropping the paclitaxel, and then we'll get into lines of therapy and things.
Yeah, so my center enrolled quite a few patients on this clinical trial. And, from that experience, I can tell you that a weekly paclitaxel after 3 to 4 months or 5 months of continuous exposure wears on our patient quality of life. There is no question that the taxane toxicity adds up, such as bone marrow suppression, neuropathy, and the fatigue that is really challenging for our patients. However, I had several patients who achieved complete remission with the weekly paclitaxel, pembrolizumab, or placebo, plus bevacizumab combination, where I ended up dropping the Taxol at the 3 months, 4 months mark, depending on how they performed, and continued for another 6 to 12 months with the additional two agents and saw an extremely durable response. As a matter of fact, two of those patients are still no evidence of disease, and they have been off of this clinical trial for over 18 months. So I would like to emphasize that I have seen some really great responders on this clinical trial, which really made me believe that with the Taxol, I was able to achieve disease remission and control of the burden, but with the addition of IO and bevacizumab combination could add the durability that I would not normally see on an Aurelia regimen with weekly Taxol and bevacizumab.
So you rained on my parade with all my excitement. Then you get me excited again with telling me patients, that you're getting CRs and seeing this prolonged. I mean, this is pretty amazing. So you at some point you got to drop the weekly paclitaxel. We
Mm-hmm.
apologize if we sometimes slip and say Taxol, but the paclitaxel. So you get a sustained response. You educate the body's immune system, right?
That's correct.
You allow that, Pembro, the PD-1 inhibitor, to educate help the
Mm-hmm.
immune system get educated. And then once you get a sustained response, once you get disease control, then in order to maintain that control after you've educated the immune system, you're keeping the Pembro going plus or minus the Bev. Am I understanding that correctly?
That's correct. Talking to investigators who enrolled large number of clinical trial patients for KEYNOTE-B96 were following the same guidelines, realizing that there could be a benefit continuing with the IO or placebo plus bevacizumab combination if the patient already derived benefit from the weekly Taxol, but given quality of life or very minimal disease burden, it was thought to be best to drop that weekly paclitaxel and then just again continuing with the maintenance phase.
All right, let's switch gears here a little bit, get into some more nitty gritty. So,
Mhm.
all right, so we have a press release talking about that the intent to treat also met its overall survival endpoint, but then we have the FDA approval that says CPS greater than or equal to 1 by an
Mhm.
FDA approved test.
Mhm.
So, are you testing everybody for CPS, excuse me, PD-L1 CPS testing? How are you doing that in clinical practice?
So they just got approved yesterday, but as of today, we are changing our clinical practice. So we will need to be testing for CPS score based on this approval. So in the past, for KEYNOTE-B96 eligibility, CPS positivity was not an enrollment criteria. It was a stratification factor, and it was tested before the patient got randomized. But we allowed to enroll PD-L1 negative patients at the time of enrollment. However, as you pointed out, the FDA approval was really focusing on the cleanest cohort where we have a really clear signal and it's very difficult to treat patient population. And for regulatory approval, this is what the FDA endorsed at this point.
All right, so now it also stated, which often doesn't comment on the number of lines of
Mhm.
therapy. I shouldn't say often, that's overstated. Sometimes
Mhm.
does. 1 to 2 prior lines of therapy. So, do you think it's important that we utilize this regimen earlier in the treatment paradigm, making sure the immune system is fully intact? I'm not sure what that means, but you don't. It's not as stressed from a bunch of additional cytotoxic therapies. What do you think about that 1 to 2 prior? Do you think we should stick with that? Or do you think people will use it outside? And I know the label is 1 to 2, but I'm asking for your clinical experience and what you'll do in your clinical practice.
Yeah, this is a great point, and I don't think we fully understand this exactly. But the intent behind Keynote B96 was is trying to select a more immunologically fit patient cohort. We do know that with prolonged chemotherapy exposure, our immune system also weakens and less likely to respond to immune checkpoint blockade. We have known that data for a while. Although most of the ovarian cancer drugs that were tested in a large phase 3 trial were PD-L1 blockades, so a little bit different from the PD-1 blockade, and also allowed for later lines of enrollment. So even though we don't have a direct proof, we suspect that the success of Keynote B96 was also hinging on the fact that these patients were less heavily pretreated compared to other patients enrolling in other randomized large phase 3 clinical trials. So going back to your point, I think it's going to be really important to use this early on and not to wait until really later lines. I think at that time point, we probably decrease the risk of us having successful response to this regimen.
I usually waited for a weekly taxane regimen. We've seen Rosella now data that showed an overall survival advantage,
Correct.
B96 overall survival advantage. I think we have ADCs coming. We already have MERV, so lots of options. But we really have to think about sequencing here. And what else do we have to think about? The regulatory landscape in platinum-resistant ovarian cancer. So I think as we've designed these trials, we haven't accounted for the superior regimen of weekly taxanes. And now with the regulatory approval and the pending PDUFA date of Rosella,
Mm.
we're going to have to account for that in our design and platinum-resistant ovarian cancer. Emmy Zeros, absolute honor to talk to you about B96. Congratulations. You really were such a champion of this regimen and this trial. Congratulations. Thank you for everything you do for our patients and to move the science forward. Please check out highlight reel just came from this winner's NRG. Check out our YouTube site, GOG. Really appreciate you taking the time today. Emmy, thank you so much.
David.